Hello everyone. Today we will continue the skull radiography lesson. Today we will learn about the radiation protection measures first. So, for the patient, avoid the repeat examinations by identifying the patient correctly. Then, giving a proper explanation about the procedure to the patient. Then, immobilizing the patient if needed. Select the optimum exposure factors according to the age and size of the patient. Follow ALARA principle as low as reasonably achievable principle. Then provide lead protective shields such as thyroid and gonadal shields. Collimate the beam properly to the area of interest. Whenever possible, use an OF. It means PA view, posterior anterior view, rather than AP technique, since this vastly reduces the eye dose. Then ask the patient to close the eyes when use AP technique to reduce the eye dose. If the patient is a lady, especially in the childbearing age, ask about the pregnancy and follow the appropriate radiation protection methods. Then for the radiographer, stay inside the lead cubicle while doing the exposure. Then for the guardians, provide a lead apron, thyroid shield and eye goggles to the guardians. Then basic radiographs of the skull. Occipitofrontal OF or posterior anterior PA radiograph. So we have to take that radiograph like these ways. First one, erect position with the erect bucky using a horizontal CR. It means using a horizontal center ray in the erect bucky. Then prone position with the table bucky using a vertical center ray. Then PA, we discuss about PA view, then AP, it means anterior posterior, or otherwise front occipital, it means OF. It is alternative to PA. We have these positions: erect position with the erect bucky using a horizontal center ray. Then supine position with the table bucky using vertical center ray. And supine position with the grid or normal cassette using a vertical center ray. Then lateral radiographs. With erect position, relevant side of the skull contacts with the erect bucky using a horizontal center ray. With prone position, relevant side of the skull contacts with the table using the table bucky and vertical center ray. With supine position, relevant side of the skull contacts with the grid cassette using a horizontal center ray. With supine, relevant side of the skull is close to the normal cassette using the air gap technique and horizontal beam. Now we are learning about occipitofrontal view or posterior anterior PA projection. Indications: fracture in the skull, trauma, it means physical injury. Then dysplasia. Dysplasia means a bone disease of the face and skull that replaces normal bone with fibrous type tissue. This tissue is not as hard as normal bone, and because it is soft and stringy, it makes the bone more fragile, and prone to break. Then diagnostic survey in abuse. Abnormal head shapes, infections and tumors affecting the skull bones, metabolic bone diseases, hematologic malignancies such as leukemia, multiple myeloma. It means skull radiographs are taken for search in musculoskeletal imaging findings of hematologic malignancies. Then detection of calcifications. Bone metastasis result in lesion or injury to the bone tissue such as lytic and sclerotic metastasis. Then, position of patient and image receptor. Prepare the patient and the equipment after identifying the patient correctly. Apply appropriate radiation protection measures to the patient. Then 2430 cassette is placed and attach the identification block. It means site marker, date, patient ID on the cassette or bucky surface. Ensure it will not interfere with the final image. Then the cassette is placed longitudinally in the bucky tray. Patient is in erect or seated or stood, facing the erect bucky or lies prone on the imaging couch so that the median sagittal plane is coincident with the midline of the bucky surface and is also perpendicular to it. Neck is flexed so that the orbitomeatal baseline or radiography baseline is perpendicular to the bucky. This can usefully be achieved by ensuring that the nose and forehead are in contact with the midline of the bucky surface. Both TMs should be equidistant from the bucky. Then patient may place the palms of each hand either side of the head out of primary beam for stability. You can see, look at these pictures. This is positioning for occipitofrontal skull projection. This is prone position. This is the correct positioning. Then direction and centering of the X-ray beam. The central ray is directed perpendicular to the image receptor, which is going along the MSP, means mid sagittal plane. Center point is external occipital protuberance. Central point is external occipital protuberance. The position of the cassette should be checked to confirm whether the center of the cassette is coincident with the horizontal center line of the primary beam. The position of the cassette should be checked to confirm whether the center of the cassette is coincident with the horizontal center line of the primary beam, and the position of the cassette should be adjusted if needed. Then collimation field should be set to include the vertex of the skull superiorly, and the region immediately below the base of the occipital bone inferiorly, and the lateral skin margins. So it include vertex of the skull superiorly, the region immediately below the base of the occipital bone inferiorly, and the lateral skin margins. Then essential image characteristics. All the cranial bones should be included within the image, including the skin margins. It is important to ensure that the skull is not rotated. This can be assessed by measuring the distance from a point in the midline of a skull to the lateral margin. If this is the same on both sides of the skull, then it is not rotated. The petrous ridges should be superimposed within the orbits. Look at this radiograph. You can see the mid-sagittal plane and lateral skin margins like that of petrous ridges. All the thing includes. This is named a radiograph. This is vertex. This is a skull margin, lateral skull margin. Then parietal bone, frontal bone, frontal sinus, lateral border of orbit. You can see clearly lateral border of orbit. Then this is a petrous ridge and lower orbital margins. You can see correctly. Then Common faults and remedies. Fault: rotation of the skull. Appearance: distance from a point in the midline of the skull to the lateral margin is not the same on both sides of the skull. Remedial action: ensure that the MSP of patient head is perpendicular to the buccal surface immediately before the exposure and EAMs are equidistant from the buccal surface. Then fault: RBL positioning error. Appearance: results the petrous ridges are not apparent within the orbits. Remedial action: ensure that the RBL is perpendicular to the buccal surface just before the exposure. Now we are moving to anterior-posterior AP projection, or we also call as fronto-occipital FO projection. Position of patient and image receptor. Prepare the patient and the equipment after identifying the patient correctly. Then apply appropriate radiation protection measures to the patient. 2430 cassette is selected and attach the lead name blocker, site marker, date, patient ID on the cassette or buccal surface. Ensure it will not interfere with the final image. Then the cassette is placed longitudinally in the buccal tray. The patient lies supine on buccal table or imagine couch with the posterior aspect of the skull resting on the table. The head is adjusted to bring the MSP at right angles to the table. In this position, the external auditory meatus are equidistant from the table. The RBL should be perpendicular to the table. Then, direction and centering of the X-ray beam. The CR, center ray, is directed perpendicular to the image receptor along the MSP. Center point is glabella. Again, center point is glabella. The beam exits from the external occipital protuberance. The position of the cassette should be checked to confirm whether the center of the cassette is coincident with the vertical center line of the primary beam, and position of the cassette should be adjusted if needed. Collimation field should be set to include the vertex of the skull superiorly, the region immediately below the base of occipital bone inferiorly, and the lateral skin margins, such like PA position. So you can see this image. This is a AP position. This is a radiograph. So now we are moving to the lateral projection. Indications. This projection is taken as a complementary image in the same situations where skull PA or AP projection is taken to demonstrate a lump. Then position of patient and image receptor. Prepare the patient and the equipment after identifying the patient correctly. Apply appropriate radiation protection measures to the patient. And a 24-30 cm cassette is selected and attach the lead name blocker, site marker, date, patient ID on the cassette or erect buccal surface. Ensure it will not interfere with the final image. It is placed transversely in the buccal tray. For the lateral position, we use transversely the cassette. If you remember, for the PA and AP projections, we use longitudinally. But the lateral projection we use transversely the cassette. Then the patient sits facing the erect buccal or lies prone on the imaging couch. The head is then rotated towards the right or left towards the affected side. if the affected side is left, we rotate the head to the left side. Or the affected side right, we rotate to the right side towards the affected side. So such that the MSB is parallel to the bucky and the interorbital line is perpendicular to it. Then the shoulders may be rotated slightly to allow the correct position to be attained and ask the patient may grip the bucky for stability. Now a special note, the choice of lateral will depend on the site of the suspected pathology. If the suspected pathology is to the left side of the head, then a left lateral should be undertaken with the cassette supported on the left side of the patient and vice versa. This will ensure that the pathology is shown at the maximum possible resolution due to minimization of geometric unsharpness. Alternatively, this can be taken with supine position using a horizontal beam. Then direction and centering of extra beam. Center ray is perpendicular to the image receptor, center to a point 5 cm superior to the external auditory meatus. It means center to a point 5 cm superior to the external auditory meatus removed from the cassette. Midpoint between the glabella and the external occipital protuberance. Midpoint of the glabella and the external occipital protuberance, or otherwise you can tell as the center to a point 5 cm superior to a external auditory meatus. Then the position of the cassette should be checked to confirm whether the center of the cassette is coincident with the horizontal center line of the primary beam, and position of the cassette should be adjusted if needed. Collimate the beam properly. Look at these radiographs. This is correct positioning. This is lateral position. This is erect bucky. This is stable bucky. Then alternative method. Essential image characteristics. The image should contain all the cranial bones and the first cervical vertebrae. Again, the image should be contain all the cranial bones and the first cervical vertebrae. In the PA and AP position, we have not mentioned about the cervical vertebrates, but in lateral position, we have to include all the cranial bones and first cervical vertebrae. Both the inner and outer skull table should be included. A true lateral will result in perfect superimposition of the lateral portions of the floors of the anterior cranial fossa. A true lateral will result in perfect superimposition of the lateral portions of the floors of the anterior cranial fossa. See, this is inner skull table, then outer skull table. You can see correctly. I will zoom. This is inner skull table. This is outer skull table. Then see, this is floor of anterior cranial fossa. Floor of anterior cranial fossa. This is sella turcica. This is mastoid air cells. This is sella turcica. This is mastoid air cells. This is floors of anterior cranial fossa. See, a true lateral will result in perfect superimposition of the lateral portions of the floors of the anterior cranial fossa. There should be perfect superimposition of the lateral portions of the floors of the anterior cranial fossa. This one is, you can see very clearly. So this is the end of the lecture. So next day we will meet with another interesting lecture. Okay, goodbye.